Good evening, everyone. My name is Deborah Hill-Bissell, and I am going to be the Exam Pro faculty who's going to be running the case list review tonight. Today's Sunday, September 11th, and for the month of September, and probably until we're done with the whole testing session, we have, for case list review, expanded our time slot by 30 minutes, so we go to 10 o'clock, and we've also added on Thursday for case list review. We have so many attendees or candidates participating, and we want to be able to give everyone as much as we can an opportunity to participate and see what it feels like to sit in the hot seat. So that's why we're doing it this way. So anyway, I am sure most all of you know how to participate, but let me just run through it in 30 seconds or less. But there's this little orange arrow up at the top that basically what it does is it opens and closes your screen. There, it looks like almost everybody, although we've already got like 45 people on, it looks like everybody is truly just using their mic and speakers from their computer, so you don't have to do a darn thing. For those of you who do have to dial in and use a telephone, if you just click on use telephone, you will get a phone number, an access code, and a PIN number. You won't be typing in questions for me, but for those, when I ask for volunteers, you will raise your hand and then I'll be able to call on you. The one thing to make sure, and there's always a little bit of a delay, but if you look underneath the orange arrow, there's the little microphone. So mine's green on my end right now because I'm unmuted. And just make sure that like you can even unmute yourself right now, and you don't have to be muted on your end because I'm the one who unmutes you on this end, and then we can listen to everybody. All right, so what we're going to do before we jump into asking for volunteers, a couple of different things. Now we're up to like 50 people and it just keeps growing. Obviously, I'm going to maybe get to 6 or 7 people tonight. So anybody who has already been called on in September for either a structured case or a case list review, please don't raise your hand. I'm going to actually lower everybody's hand. So if you've gone in September, please don't raise your hand and let's try to give everybody an opportunity. All right, so what I like to do, we all have the ability to do this a little bit differently. I always like to start even the case list review off with just like my little 2 or 3 minute lecture or my clinical pearls, I'm going to call it. So this is from the Society of MFM. It's their consult series from February of 2021. And it's on intrahepatic cholestasis of pregnancy. And so when you go to the ACOG website, they have, the practice bulletins and then the clinical bulletins or whatever they call them now. They changed the names. And then if you keep going across, they have something called ACOG endorsed. So this is one of the ACOG endorsed publications. So really just, I've got two or three slides. Let's just go through this really quickly. So intrahepatic cholestasis of pregnancy is a hepatic disorder characterized by pruritus and elevation of the serum bile acids. All right, you guys all know that. The fetal risks, of course, stillbirth is the one we worry about the most, preterm delivery, and also meconium stained amniotic fluids. So what does the Society of MFM, what do they say recommend? They say anybody who has suspected ICP, you should measure serum bile acids and liver transaminases. You guys know that. They also say ursodeoxycholic acid should be used first line to treat maternal symptoms. A lot of times we talk about, giving things like hydroxyzine to help with sleep, etc. But this is right from the Society of MFM. That's what we're going to use first line. Then, as for when you should start antenatal fetal surveillance, this is what they say. You should start it at an age when delivery would be performed in response to abnormal fetal testing. So if you wouldn't deliver somebody based off an abnormal test, don't start testing yet. Or at the time of diagnosis if the diagnosis is made later in pregnancy. However, they do say the optimal frequency of testing is truly unknown. And if the examiner asks you, well, how often are you going to do testing? Tell them what you do in your institution, what's the policy, maybe what your MFM recommends, but do know that that it's not clear cut. One of the things that they looked at in this publication was the basing management off of bile acid levels. So patients who have total bile acid levels greater than 100 should be delivered at 36 weeks. You can deliver patients who have bile acids less than 100, they give us a pretty big range here, deliver between 36 and 39 weeks. However, they say if these are for people with less than 100 bile acids, but if the bile acids are less than 40, go more toward the later end of the spectrum, like, 37, 38, even to 39 weeks, although I'm not really too comfortable with that, but you can definitely push it more to 37, 38 weeks. If it's greater than 40, but less than 100, you're still going to want to deliver them on the earlier part of this spread. And then, of course, you should give antenatal corticosteroids for patients delivering before 37 weeks if corticosteroids had not been previously given. And they do recommend against delivery at less than 37 weeks in a patient who has a clinical diagnosis of ICP, but you do not yet have lab confirmation of elevated bile acids. So how do you actually make the diagnosis of ICP? It's a clinical diagnosis. It's based on the pruritic symptoms and usually like when it presents, lack of rash, you've ruled out other causes. It is supported by elevated bile acids. Total serum bile acid level greater than 10 is usually used to diagnose ICP, although data is limited if that's really what we should be using. So that's just kind of for you guys to know. So you can consider delivery between 34 and 36 weeks if the bile acids are greater than 100 plus any one of these three following things: excruciating, unremitting maternal pruritus not relieved with pharmacotherapy, or a history of a stillbirth before 36 weeks due to ICP with recurring ICP in the current pregnancy, or pre-existing or acute hepatic disease with clinical or lab evidence of worsening hepatic function. So there you go. That's your little pearl for today on ICP from that publication of Society for MFMs. All right, so let me kind of start toward the bottom, and then I'll just kind of work up and we'll start calling on people. All right, so let me get out of here and pull up your case list. Great, so let me get rid of that. Now I've got your case list. All right, so now let me go with Tiffany. All right, Tiffany, I'm trying to get you. There you go. How are you?
Good, doing well. How about yourself?
You don't want to know. I'm really tired today, but I'm going to be as chipper as I can be. Okay. Okay, so are you a generalist, Tiffany?
No, I'm a GYN oncology fellow.
Okay. All right, so let me find you. What do you have a particular case list or case that you want to discuss? Oh, that's the other thing too, you guys, just so you know, sometimes candidates just have a case that they're really worried about and they would just like to share it with everyone and also see how they would defend it. That's fine too. So when I call on you, if you know ahead of time what case list you would like to do, and specifically if there's a particular case, just let me know. All right, so Tiffany, what would you like to do? Wouldn't you like something like not GYN?
Either OB or office would be great.
Yeah, I would think so too, because that's, you're going to know more about GYN oncology than the examiner's questioning you. So really, when you look at your GYN case list, you should really focus on the cases that were like benign cases. And also, like if there were adnexal masses or things like that, focus on, you know, what would I do if this was a 19-year-old G0P0 and I wanted to preserve fertility, and what would my differential diagnosis be? Do you know what I'm saying? Things like that, like how could you look at that and say, what could they ask me, and make this more of a benign type presentation. All right, so let me see here. All right, let's just go right here. You have a 32-year-old G1P0 at 40 weeks and 4 days. And you induced her. Tell me why you induced her.
In this patient, she came in for an elective induction at 40 and 4.
Okay. What is the ARRIVE trial? And how did the results of that trial change our management of induction of labor?
So the ARRIVE trial is a randomized controlled trial looking at the intervention of elective induction at 39 weeks rather than the standard of care, which would just be sort of a no inductions, so expectant management for women, low risk women with no indication for induction.
Okay, and go ahead. And what did it find?
So I believe their primary outcome was rate of cesarean section, and what they found was that there was no difference between the arms in terms of rates of cesarean section. There were no increased risks to the fetus, including need for a higher level of care, for example, the NICU, intraventricular hemorrhage, or respiratory distress syndrome.
Excellent. So what else? What about maternal? Was there anything else besides no increased risk of C-section? Anything other advantages they saw of induction at 39 weeks?
I would be going out on a limb here, but I believe they might have found increased maternal satisfaction with the procedure, decreased risk of hemorrhage, decreased, I guess this goes back to fetal, but decreased meconium.
Okay. All right. So then you started your induction. And so you did misoprostol and then an intracervical Foley. So when you go to induce somebody, how do you determine who needs cervical ripening and who doesn't?
So I would start off with a cervical exam, and based upon their cervical exam, I would calculate a Bishop score. And if their Bishop score was below 8, I would determine that they would need a little bit of cervical ripening. And so my go-to would be to start with a misoprostol.
Okay. And so then tell me about intracervical Foley. Why did you also do that?
So in this nulliparous patient, in addition to the misoprostol, I also placed an intracervical Foley because she was 1 centimeter and her cervix was still long. In our institution where I did residency, it was our practice for nullips who needed cervical ripening to do the 2 methods simultaneously to decrease the amount of time to full dilation.
Okay, so what happened first in the middle? Did she develop arrest of dilation or chorioamnionitis, or did they kind of both occur at the same time?
In this patient, she developed chorioamnionitis shortly before, a couple hours before she was called for arrest of dilation.
Okay, and so how did you make that diagnosis of chorio?
So first she developed fetal tachycardia and subsequently developed a fever above 38 degrees Celsius that was persistent over an hour.
Okay, and so then what antibiotics did you place her on?
We placed her on ampicillin as 2 grams. We started with 2 grams every 6 hours, and then also started her on gentamicin with a 1.5 milligram per kg loading dose.
All right, so let's talk about the arrest of dilation. How do you actually make that diagnosis?
So this would occur in a woman who is 6 centimeters dilated or more, who is found to have adequate uterine contractions, and who has not made any cervical change or descent in either 4 hours of adequate contractions or 6 hours without adequate contractions.
And how would you know if contractions were adequate?
So this could be done through the use of an intrauterine pressure catheter placed vaginally, which measures the total amount of uterine contractions measured in montevideo units.
And so when you have an IUPC in place and you're going to have to calculate if these are adequate, Tiffany, how do you actually do that?
So the IUPC, so I would count the number of Montevideo units from the peak of the contraction and subtract out the baseline number of units. And within a 10-minute period, I would count the number of contractions and sum up the number of Montevideo units. And if it was greater than or equal to 200, she would be considered adequate, and if less, then not.
Excellent. Okay, I think you did a great job. I really did. I think you hit on everything. So for a GYN oncologist, I say good for you. Let me just go back to the ARRIVE trial real quickly. You did a great job. I just want to tweak the end part a little bit. You're right. So this was a multi-center study that looked at over 4,500 low-risk nulliparous women. And at 39 weeks, they were either randomized to immediate induction or expectant management. What was interesting was at the time of randomization, almost 2/3, it was like 62% of the induction group had Bishop scores less than 6. This is in nulliparous women. Okay, so they were sure we were going to see more C-sections in the induction group. What they actually found was less C-sections. I mean, it was only by 1.4%, but the bottom line is there was not an increased C-section rate in the induction at 39-week group. But they also found, Tiffany, which you discussed, was less NICU admissions. The other thing they found, and this makes sense because we're delivering the mom sooner, less gestational hypertension and less preeclampsia. So based off the findings of the ARRIVE trial, ACOG says it is reasonable to offer induction at 39 weeks to anyone. And it's such a change from a couple of years ago when we'd be reviewing case lists, we'd be saying, don't put elective induction down. You know, you got to have a reason like they live too far from home or something like that. And now everybody can have one. Okay. Do you have any questions for me?
No, that was perfect. Thank you.
Okay, thank you. All right, so let me keep seeing who's next. Hey, Patricia, I'm going to go out and try to find you. How are you doing this evening? Hello? Hey, Patricia, I can't hear you. Patricia, if you're speaking, I don't hear you. Is your microphone plugged in? Now I can hear you. Now I can hear you.
I actually haven't submitted my case list yet to you. I'm sorry. Can I be called on another day? I apologize.
You betcha. You bet. Okay, thank you. All right, so let me just keep going up here. So again, anyone who hasn't gone this month. Matthew. I'm just waiting for you to unmute yourself. There you go.
Hello.
How are you doing?
Good.
How are you doing? Good.
Good.
And are you a generalist?
I am.
All righty. So tell me what case list we're going to do today.
I guess we did OB, so we can do officer GYN.
All righty. Let's do an office because everybody hates it. Let me just jump through here a little bit. All right, let's just jump in and do a PCOS because I'm sure you'll probably get asked about that. So you had a 20-year-old patient who was obese and had experienced some weight gain who came in to see you with a history of infrequent menses and was complaining of hirsutism. So you did her history and physical, her HCG was negative. You did an ultrasound, you looked at the different multiple follicles, and you did this blood work, a lipid panel, TSH, and an A1C. So how'd you make the diagnosis of PCOS?
So for this patient, she had a long-standing history of oligomenorrhea, which is 2 out of the 3 typically have to be present according to the Rotterdam criteria. So she also had a long-standing history of unwanted hair growth. So clinically, you can make a diagnosis of hyperandrogenism for her. She actually came with an ultrasound that showed multiple antral follicles, and so she actually met all 3 criteria for PCOS.
But in order to make the diagnosis of PCOS, what do you have to rule out? Like, what are other causes of oligomenorrhea? One is pregnancy, which you ruled out with the HCG, but what else should you have tested for?
So I also evaluated for thyroid disorders with her TSH, which was normal, and I guess initially those were my main concerns for an otherwise healthy 20-year-old.
Okay, so how would you know this wasn't with her oligomenorrhea, obesity, hirsutism, and polycystic ovaries? How would you know this wasn't congenital adrenal hyperplasia, 21-hydroxylase deficiency?
Sure. So for her, she had no other than weight gain. She hadn't had any weight disturbances. She also had otherwise, realistically, she had no other complaints. And I know that the most likely etiology, given her symptomatology, is PCOS. However, I guess I hadn't gotten a workup for congenital adrenal hyperplasia. So,
Are there any like nationalities or ethnicities that's more common in?
I'm not aware of any. It's not to say that there aren't, I'm just not aware of any.
Okay, so anyway, so then you tell her about this PCOS, and you did do a hemoglobin A1C and a lipid panel, looking for any evidence, obviously, of like pre-diabetes or diabetes, as well as metabolic syndrome. So how do you counsel somebody who has PCOS about what are some of the long-term health complications?
Sure. So in a patient with diagnosis of PCOS, there are multiple considerations, especially with the 20-year-old who had considerations for fertility in the next several years. There's an increased risk of infertility in a patient with PCOS. There's also increased risk of diabetes or pre-diabetes, and there's also risk of lipid disorders or dyslipidemia. Patients can also have an increased risk of endometrial hyperplasia or endometrial precancer or cancer with chronic unopposed estrogen exposure. And then there's also a psychosocial component with patients who typically have like obesity or hirsutism, so they can have increased rates of depression as well.
Okay, good. All right, so then you talked about lifestyle modifications. Tell me what you recommended for her.
So we discussed diet and exercise. So main thing with weight loss is actually 80% of, I counsel patients that 80% of weight loss or weight management is actually diet related. So avoiding empty, what we call empty carbohydrates or, non-complex carbohydrates, avoiding like breads, pastas, sugary drinks, and steering more towards complex carbohydrates, like peanut butters, legumes, and then other proteins, avoiding things that are snacking tendencies, and sticking to fresh fruits and vegetables wherever possible. We also discussed weight loss, so exercise, 150 minutes a week of moderate intensity exercise can also help improve patients' overall, risk of diabetes or pre-diabetes, as well as dyslipidemia and weight. So those are,
oftentimes, oh, I'm sorry, go ahead.
Yeah, that's it, that's all.
Okay, so it's oftentimes very overwhelming for these patients when we talk about weight loss. Tell me how you counsel them with the amount of weight loss that is required, that they may actually even start spontaneously menstruating.
Sure, so I counsel patients that drastic changes are necessary in order to achieve, like you said, regular menstruation. So roughly 5 to 10% of losing 5% of weight, their body weight, can actually improve menstruation and overall fertility as well.
When would you consider putting somebody with PCOS on metformin?
Typically, if they had, in my practice, I would typically do it if they had an abnormal hemoglobin A1C showing diabetes or prediabetes.
Okay, so in this case, she comes in with her oligomenorrhea, obesity, weight gain, and hirsutism. So you talked about the lifestyle modifications and you prescribed oral contraceptive pills. Tell me how that is, what that's treating, and what's the underlying mechanism that it's going to help her with her oligomenorrhea and her hirsutism.
Sure. So it's multifactorial as far as the effect of combination OCPs. The main mechanism that we're concerned about is with regard to her oligomenorrhea, which, like I said, unopposed estrogen exposure can lead to endometrial hyperplasia long term, or even endometrial cancer. So reducing that risk with combination OCPs is my main concern. However, it also does increase sex hormone binding globulin within the bloodstream, so that also binds to androgens like testosterone that could potentially decrease her hirsutism and unwanted hair growth.
Okay, and let's see, what else could I ask you on this? Let's say look at patient number 19 because she's 29. Let's say she does desire conception. Would you attempt ovulation induction, or would you send her to REI?
Typically, I would send them to REI. However, I do know that it is quite expensive to go to REI. So if she did not have the fiscal means, I could potentially work with my partners in my group, as I do know that I have partners in my group who are also generalists who perform ovulation induction.
Okay, and so for PCOS, which ovulation induction agent is preferred, and why?
Letrozole is the preferred agent. Clomiphene is no longer the preferred agent just because letrozole has increased has a higher incidence of live birth rates compared to clomiphene citrate.
Okay, good. All right, I'm gonna let you take a deep breath. I think you did absolutely fine, but I just want to tweak one thing here with PCOS. So you're absolutely right that it's we use the Rotterdam criteria to diagnose it. So we're looking at 2 out of the 3, oligomenorrhea, clinical signs of hyperandrogenism or laboratory signs of hyperandrogenism, and polycystic ovaries on ultrasound. And you're right, this patient had 3 of them. But before we can use the Rotterdam criteria, we have to rule out other causes for oligomenorrhea. So that comes first. So
Okay.
you have to do a pregnancy test, you've got to do a TSH, you've got to do a prolactin level. Now, you could argue for even doing an FSH on the tiny chance she had like premature ovarian insufficiency. So that wouldn't be wrong, but you don't have to do it. So you've got to rule out the other causes first. Once you've ruled those out, then you can take a look at the patient and make the diagnosis of PCOS.
Okay. And in my practice, just because many times I'll get a mildly elevated prolactin level, and then I can get a mcRoberts after that. But I typically ask for symptoms of tunnel vision or difficulty seeing peripherally or abnormal nipple discharge, just as like screening questions. With that, I know that doesn't suffice as like a prolactin, but it's just I get so many like mild.
I understand. You know what? And I understand exactly what you're saying in real life, but for
Yeah.
the test, Matthew,
Okay.
tell them you get a prolactin. Tell them
Okay.
you rule out other causes of oligomenorrhea first, and then you go to the Rotterdam criteria. But you did a great job with the OCPs and the lifestyle modifications, and I like the way that you discuss with them with some concrete ways that they can try to reduce calorie count. So I think that was excellent.
Okay. Great.
All right.
Thank you so much.
Thank you. Maria, let's get you in here. So Maria, you're still muted on your end. Are you there? There you go. Okay, Maria, you're there, right? I don't know why this is not having trouble hearing the people. So Maria, I cannot hear you. You're unmuted on your end and unmuted on mine. So I'm not sure why I can't hear you speaking. Are you plugged in? All right, I'm gonna have to go to somebody else. All right, let's see here. Caitlin, let's see if I can reach you.
I'm here.
Yay! All right, a voice. Are you a generalist?
Yes, ma'am, I am.
Okay, all right. So you tell me what you would like us to do.
Dealer's choice. I'm fine with anything.
Okay, I guess we might as well hit a GYN because we haven't done that one yet. We'll kind of keep it mixed up. All right, when do you actually test?
I'm the first testing group in October.
Okay, yeah, they haven't sent out the date yet, have they?
No, not the exact date, just the week, the 17th.
Yeah, yep. Aren't you guys also happy you can do it from home and you don't have to travel?
Yeah, I actually am.
Yeah, I think it's a lot. Hey, just so you know, you do have some TVHs on your case list, and I want to reassure the candidates who don't have TVHs. I have been reviewing case lists for over 10 years. Each year, the number of TVHs truly does decrease, and I would say of all the case lists I reviewed this year, and it was a lot, I would say 5% or less of the candidates have a TVH on it. So that's just for your reference, and I just want you to know that. All right, so let me see here. Yeah, let's do this one. You have a 26-year-old. So here's, they're going to ask you, here's a young age hysterectomy, which when I look at her pathology, it looks normal.
Yes,
So
ma'am.
let's have you present this patient to me and tell me how and why you ended up doing a hysterectomy on a 26-year-old with normal pathology.
Sure. So this was a 26-year-old G3P2 who came to me very frustrated with her continued sort of dysmenorrhea and abnormal uterine bleeding. She had a full sort of workup, as you can see, including a pelvic ultrasound and an endometrial biopsy that were benign, and had previously tried multiple forms of birth control, including oral contraceptives. She tried Depo, Provera. She had tried, I think when she came to me, she was on an IUD. And while these controlled her bleeding for in some way, she still felt like her bleeding was interrupting her sort of daily life. She's a very active individual. She's actually a gymnastics teacher. And so she felt like she was done childbearing. She had been done childbearing for a while, and her husband was actually status post vasectomy. And through an extensive conversation, felt that the best way forward for her was a hysterectomy.
All right, so on exam, because she has dysmenorrhea, on exam, did her uterus feel tender? Did it feel boggy? Was there anything that made you suspicious for adenomyosis?
So she had a pretty largely normal exam. Obviously with dysmenorrhea, I worry about, especially if I'm going to do a vaginal hysterectomy, I worry about intra-abdominal pathology that could be contributing to that, or something like adenomyosis that can make the surgery a little bit more difficult or a little bit more bloody. But her exam was very benign. I didn't feel like her uterus was super boggy. She had a little bit of tenderness with sort of deep palpation, but nothing that was overly concerning.
Why not an endometrial ablation?
For her age group, I don't find that endometrial ablations are a great option, largely because the number of women who need a repeat procedure at 5 or 10 years is so high. And then if she does need a repeat procedure, often that procedure becomes more difficult because of the prior endometrial ablation. That was an option that we talked about, but given the risk of repeat procedure at 5 or 10 years or earlier, she did not desire that.
Okay, and so you said that she had tried OCPs, Depo had a levonorgestrel IUD in place. With the OCPs, was she ever just put on continuous OCPs?
If I recall, yes.
Okay, all right, so then you do this TVH. Tell me what you did to help suspend that vaginal apex so to minimize the chance that this young woman who's active is going to end up with vaginal vault prolapse in the future.
Sure. My standard is to do a mccall's culdoplasty on all patients in order to help suspend that vaginal vault back to the uterosacral ligaments.
Describe that procedure. Tell me how you do it.
So once the uterus has been completely removed, I should already have stitches tagged on the uterosacral ligaments from that removal. But if I don't, then I'll grab the uterosacral ligaments with an Alice clamp. I check to ensure that I have it digitally to, triple check myself to make sure that that uterosacral ligament is included there. I throw a stitch through the uterosacral ligament on one side, kind of skive across the posterior cul-de-sac, and then through the uterosacral ligament on the other side, and then tie that suture together so that it brings those uterosacral ligaments back together in the midline, fully suspending that vaginal cuff.
Okay, and so when you're doing the getting the uterosacral ligaments, tell me where the ureter is in relationship to where you're placing your needle and your suture.
So generally, the ureter should kind of pass slightly posterior laterally to the uterosacral ligament. So ensuring that you're kind of pulling that uterosacral ligament out and away from the side wall to ensure that you're not incorporating that.
When you tie that down, do you know like what percentage of the time with a mccall's culdoplasty that we can actually kind of kink the ureters?
So I'm not exactly sure of the exact number. I know it's it's like less than 1%. It's pretty rare, if I recall correctly. In my practice, we do cystoscopies on all patients prior to ensure that they have a brisk ureteral flow bilaterally.
That was going to be my next question, that it appears you do cystoscopies on all of your hysterectomies. And I was going to ask you, you know, that's kind of a source of controversy of should you do it on everybody or shouldn't you? Tell me what's the thought in your practice of why you do cystoscopies on everyone?
So I think when we look at the risk benefit to cystoscopy, it, in my practice, weighs towards doing the cystoscopy. Certainly there's an increased risk of things like you know, urinary tract infection being the major one. However, at the facility where I work, having a complication such as a blocked ureter that you don't find intraoperatively can result in a long delay in transfer, you know, increased risk of, you know, worse outcomes. And so in my practice, the risk benefit kind of weighs towards doing the cystoscopy at time of procedure.
Okay, just like you said, the naysayers who say we shouldn't do it, they're the ones that talk about, hey, there's increased risk of UTI, you're increasing OR time, you're increasing the cost, and it doesn't increase the detection of delayed ureteral damage, like a thermal injury, etc. But I agree with you. But if you can find something at the time that it's done, it's a whole lot better to fix it then than to fix it later. All right, let me see if there's anything else I would want to ask you. Oh, what should a normal uterus weigh? Her uterus weighed 111 grams. Why do they even want us to put the weight of a uterus down, and what should it weigh?
I think the average weight of a uterus is somewhere between like 80 and 120, if I remember right, grams. And it's largely looking for pathology. So things like adenomyosis, large fibroids, those types of things will make a uterus weigh more and can increase the, you know, the risk of things like abnormal uterine bleeding, dysmenorrhea that lead us to having a hysterectomy.
Okay, good. I'm gonna just stop here for a minute. I think you did great. As for let me just go over it. As for weight of the uterus, I have read so many different things. 60 to 80 grams is what I've read, and then if you're multiparous, maybe up to 100 grams. So that's why I was looking at her going, okay, it's not much more than that, but I wonder if there was some adenomyosis component. That's why I was pushing you on. So was her uterus boggy? Was it a little bit tender? You know, because a lot of times the pathologists don't call adenomyosis, even though clinically we're like, I know this woman had adenomyosis. But anyway, so that was my big question there. With regards to the cystoscopy, you did a nice job explaining why you do it, but actually it's up to 10% of the time when we do a mccall's, we can kink the ureters. So ACOG actually says, you do a mccall's culdoplasty, you do a cystoscopy.
Okay,
so
great.
So there you go. All right, great. Any questions for me? I think you did a really nice job. But I could totally see anybody who, if you have young age hysterectomies, anybody less than 40, especially associated with low parity, doesn't mean you did anything wrong, but don't be surprised if they don't focus on those to say, are you some overly aggressive surgeon?
And I think
okay.
I'm particularly worried because I do have, most of my hysterectomies are less than age 40. Because I was in a small practice and the only one case collecting, a lot of the hysterectomies came to me. And so I'm like worried that that's going to show that I'm aggressive when really it's just that I got a lot of my partner's hysterectomies, you know?
And so, yep. And so what you could say if they said to you something like, oh, let's see, like here's your 28-year-old, and another 28-year-old. If these truly were patients of your partners, you could say, this patient was a patient of my partner who had presented with blah, 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 blah. They had discussed, you know, all this stuff. And then you could even say something like, then they referred her to me to do the hysterectomy. I reviewed her records, reviewed everything that had been done. Again, I talked through all of my different options that she could try, and the patient, after multiple visits and counseling sessions, the patient was still adamant she wished to proceed with hysterectomy because her uterus and the bleeding and pain, whatever, was truly running her life, and she no longer wished to have that quality of life.
Okay.
Does
Thank you,
that
ma'am.
kind of make sense? Yeah.
Yes.
And that's how I would approach it. But definitely you can say that this was during your case collection. You could even tell them that some of these patients were your partner's patients, that they referred them to you.
Okay, great. Thank you so much, ma'am.
Okay. Uh-huh. Hey, Jennifer.
Hello.
So how you doing? I'm gonna pull up
Hello,
your.
how are you?
Are you a generalist?
Yes, ma'am.
Okay. All right. So what case would you like? What case list would you like to do?
I feel like we've covered all three, so I guess I can
We
leave it
have.
at your.
All right. So we just did. Let's just keep going down the line then. Let's hit a OB. And let me just I'm gonna scroll. We always tend to, do the ones right in the beginning because we don't do all this scrolling. So let me go further back and see what I could do. This is an interesting one. Let's look at patient 41. So you had a patient who was at 26 G1P0 at 14 week and 5 days. So she had trichomonas. So you went ahead and tell me how you treat trichomonas in pregnancy.
For trichomonas infections, normally when the patient is less than 12 weeks gestation, I try to avoid the PO metronidazole. But unfortunately, that's the only way the patient can be treated. You can treat them with metronidazole PO, 500 milligrams BID for 7 days, which is the sort of preferred treatment over the one-time 2-gram oral dose.
Okay, and so how do you counsel her in addition to treating her trichomonas? Then tell me how you're going to counsel her about safe sex, about the partner, when are you going to retest her, all that type of stuff in pregnancy. How do you manage it?
So I normally try to do the expedited partner treatment, so provide him treatment as well. I tell the patient, and if her partner is available, speak to him as well, or she will pass on the information that 1 week after taking the medication is when they could potentially engage in sexual activity again, but they have to abstain for 1 whole week after completing the course of the medication. And testing can be redone at the 3 to 4 week time period.
All right, so then tell me how you made the syphilis diagnosis.
So for the new OB labs, it's routine and standard to get, in my practice, the RPR. Her RPR was reactive. I then proceeded with the fluorescent treponema antibody testing, which was also positive. So this confirmed that she had a diagnosis of syphilis, and also with the RPR titer level as well.
So tell me, what stage of syphilis was she, and how do you determine that?
So if the patient is less than a year, that's considered early stage, and then they have a latent stage, which is more than a year. Yes.
So if she has a severe penicillin allergy, what is the recommended treatment for syphilis in pregnancy?
It's still PenG. Unfortunately, that's the only option. However, she needed to be hospitalized for a desensitization.
Okay, and so how many doses of penicillin did she have? What did you decide she was? Early
So,
latent, late latent? What did you decide?
so for this patient, she actually stated that a couple years ago, she was told that she had this diagnosis and she never followed up. So hers would be considered late latent, and she needed to get a total of 3 doses of the PenG to complete her
And
treatment.
then, okay, and so then when you're following the RPR, how often are you going to follow that, and what amount of a decline are we looking for to see, quote, what we would consider successful treatment?
You would need to see it change by a 4-fold. And for this patient, I checked it again. What's the time frame that I did? I checked this again for the patient at the like 6 to 8 week time period.
All right, so then is this patient at risk for having a fetus infected with syphilis?
Yes.
Okay, and what are some of the signs and that, or what is congenital syphilis? What are some of the like clinical findings that we could see in a fetus with congenital syphilis?
They can have skin lesions. Something that I feel like we've seen a lot in med school is like the sniffle sign, where they can have, it's actually like the treponema molecule that can be found in their mucous membrane. So we can see that the treponema antibody kind of in their mucous membranes, and it's in that nasal area. And I believe they can also have some neural abnormalities as well.
Okay. I'm trying to think what else. I think that's pretty much the main thing. So you're right. Trichomonas, we're going to do it with the even if she wasn't pregnant, the new CDC says we treat it all for a week now. The guy can still just do the one-time dose. If she wasn't pregnant, we wouldn't have to do a test of cure in 3 to 4 weeks. We would just do a test of reinfection in 3 months. This patient should get a test of cure and then still be tested again like in 3 months out, looking for reinfection. But the syphilis thing, that was definitely the interesting one. So when we look at syphilis, you can have primary syphilis, right? That's the person who shows up with a chancre. They won't even have a positive RPR yet because the syphilis, the spirochete is still all in that skin lesion. It hasn't even made it into the bloodstream yet. So that would be truly, they just have this painless lesion. Then secondary syphilis is when it goes systemic, and that's when they can get the rash on their palms, where they can get it on their soles, they can get fever, the lymphadenopathy, etc. Just think about the spirochetes throughout their system and they're definitely infectious then. Then it goes into latent, where like they don't really have any symptoms, but you get a positive RPR. And you're right. So early latent would be, let's say a year ago, she was seen and her RPR was negative, and then all of a sudden you test her and it's positive. So basically in a 12-month time or less, she went from negative to positive. So that would be a early latent. You would treat her with 1 dose. The late latent would be if it was greater than a year or unknown, that she never ever had a test done. So you don't have anything to compare, then you would err on treating her as a late latent and would get the weekly dose times 3. And you're absolutely right. Pregnancy, you got to be treated with penicillin, and so you have to send them to the hospital and sensitize them. And the incidence of syphilis and congenital syphilis has gone up tremendously in the last 10 or so years. And so I could totally see that being a question. If it wasn't even on your case list, maybe even a structured case for the OB case list. So good. Any questions for me?
Can you go over what are some of the signs of congenital syphilis?
You know, they can get the disformed teeth. They can get brain calcifications. That's all with part of that neurodevelopment. You can have like pregnancy loss. And truthfully, I would have to actually look it up, Jennifer, what some of the other signs and of congenital syphilis were. But for you, I don't have to take the test, but you do. But definitely know what congenital syphilis should look like. Okay, because I could see them asking you that. And like, especially by ultrasound, what would you be looking for? And I know they can get, calcifications in the brain and stuff like that.
Okay, thank you so
Okay,
much.
all right. Thanks, Jennifer. Let's go to Hannah. Hannah, you're still muted on your end.
Hi, can you hear me?
Yep, I sure can. All right, so are you a generalist?
Yes.
All right, and do you have a particular case list or case you'd like to go over?
No, let's just keep going in order.
All righty, so we'll jump to office now. Let me see here. Let me try to jump toward the back and see if we can come up with something. All right, let's look at patient number 37. Okay, so this was a 40-year-old G0P0 who had been diagnosed with a BRCA2 mutation. Hannah, do you remember what was her family history that had led her to actually be tested for this?
I believe her mother was diagnosed with breast cancer, and that led to a BRCA2 diagnosis, which then prompted her and other family members to be eligible for testing.
Okay, and so with regards to BRCA2 versus BRCA1, tell me with BRCA2 which cancers are increased, and then especially tell me about the ovarian cancer component. What's different in BRCA2 versus BRCA1?
So breast cancers that are found in the cluster of cancers with BRCA2 are breast cancer, ovarian cancer, melanoma, as well as prostate cancer. And then ovarian cancer risk is approximately about 25% in these patients.
And with regards to BRCA2 ovarian cancer versus BRCA1, tell me which one tends to occur later.
So BRCA2 occurs later, and therefore the counseling regarding prophylactic BSO is between age 40 to 45.
So tell me why, when GYN oncology counseled her, tell me why you think they did the bilateral salpingectomy, 6 or 8 years ago.
So this patient, she was never interested in childbearing. She has a female partner who gave birth to their children. And so from a young age, this patient was ready to consider BSO prophylaxis. However, given the risk of premature menopause, she was counseled that she would be a better candidate between age 40 to 45. However, she did undergo bilateral salpingectomy as there is increased risk of development of ovarian cancer from the distal end of the tube. So at that time, that was considered an appropriate measure to take until she was in the age range eligible for BSO.
So she's truly not had cancer yet. She hasn't had breast cancer or anything. So what is she doing for breast cancer surveillance?
So at the time that I met her, she had met once with she had actually only met with GYN oncology at that time. So she had not She had been counseled about alternating 6 months MRI and mammogram, however, had not yet initiated that screening, and that is part of the conversation that I had with this patient.
Okay, and so has she since instituted that now?
She has not. She was since I ordered both of those screening tests and also referred her to breast surgeon because she was interested in discussing medication prophylaxis and possibly bilateral mastectomy, but she has not yet instituted that, and that's just based on her own initiation at this point.
Okay, so back when she got the bilateral salpingectomy and she's not interested in pregnancy and she doesn't have breast cancer, is there any sort of chemoprophylaxis that, and I'm going to put quotes around that, that you could have offered her to reduce her risk of ovarian cancer?
So the medications that can reduce the risk of ovarian cancer could consider oral contraceptives. And then as far as other options for ovarian risk reduction,
That's pretty much it.
I think that's it. For breast cancer reduction, she could consider tamoxifen.
Yeah, there you go. So she could consider tamoxifen, which with, why is tamoxifen especially more helpful for BRCA2s than BRCA1? Do you know?
So for BRCA2,
For prophylaxis.
I do not know.
Okay, I'm going to jump out of exam mode. Believe it or well, BRCA1 tends to be the triple negative breast cancers, and so they tend to be hormone receptor negative. And really, tamoxifen has not been shown to reduce breast cancer with BRCA1, but it has with BRCA2. Okay, so that she actually could have been on tamoxifen. And then let's see here, what else? And then she got her tubes removed. She's considering getting her ovaries removed. So tell me about the BRCA though. I mean, how is it inherited? So if she had chose to have children, what's the risk that her child could have carried this mutation?
So it is inherited in an autosomal dominant fashion, so 50% risk of inheritance.
Okay, again, in this patient who has not had breast cancer or ovarian cancer, if you go and take out her ovaries, would you put her on estrogen?
Yes, she would be a candidate for hormone replacement therapy.
Okay, and I guess I'm trying to think if there's anything else I wanted to ask. What type of a history would make you, family history, would make you be suspicious of a possible hereditary cancer syndrome, and where you would recommend the patient consider be tested?
So either on a maternal or paternal side, multiple family members, especially closely related, so siblings or parents, either with female or male breast cancer, and then the addition of ovarian cancer, and especially for both of those, diagnosis premenopausally, and then with the addition of other family members with prostate cancer or melanoma would be suspicious as well.
Okay, excellent. All right, so and then the purpose of your ultrasound was what?
So for patients who are considering risk reducing surgery for a short course of time, there is no data to suggest, but it is reasonable to suggest that you can do screening with a pelvic ultrasound in consideration of a CA-125, though it's important to discuss with these patients that there is no screening test that is truly preventative for ovarian cancer, and so that they should be moving towards decision-making regarding prophylactic surgery.
Perfect, perfect. And that's exactly right. You know, you can do an ultrasound and a CA-125 even every 6 months while you were just kicking the can down the road waiting to remove the ovaries, because that's going to be for sure the most effective. And you're absolutely right. If they haven't had breast cancer, then actually we should put them on estrogen until the average age of menopause, because that has not been shown to increase the breast cancer risk even in the BRCA patients. Let me see, what else did I want? Oh, and then just to remember too, you guys, when you do your wellness exams, when you're looking at like things like quote age appropriate, screening, just remember there's like 5 things that ACOG wants us to screen for at every annual exam, and it doesn't matter if they're 18 or 88, but everybody, we're supposed to screen for intimate partner violence, depression, and every year we're supposed to update the patient's family history looking for evidence of hereditary cancer syndrome. So ACOG has made that very clear. And then we're supposed to screen for substance abuse and make sure they're up to date on their vaccines. So that's kind of just a real easy 5-item thing that you're going to do at everybody's wellness. But what made me think about it was the fact that ACOG does want us to update family history annually, and now it's a lot more than just BRCA1 or BRCA2. We know there's so many other mutations that I just order that myriad my risk, and gosh, I can't even remember all the little alphabetical stuff that they can check for, but it's important that we're aware of that. So good. Thank you very much. Any questions for me, Hannah?
Could we just review if it's asked how to perform prophylactic BSO?
Oh, sure.
Like if you would ask me that question, then I'm happy to give you my best attempt at it, or if it's easier for you just to answer for the group.
So in somebody that you are going to do a risk reducing BSO for somebody who has a BRCA2 mutation, tell me, number one, how you're going to do it, and then what you're going to ask of the pathologist.
So I would do this surgery laparoscopically unless there was any other reason she needed a different type of procedure. My first step would be inspection and washings that I would send as pathology. And then for the BSO itself, it's important to remove the entirety of the ovary. So going about a centimeter, distally on the IP ligament, and in this scenario, being very careful about visualizing the ureter, and then going all the way to the cornea of the uterus when you do the self-injectomy, and then removing them in a bag in the event that you might find potential early cancer that you don't see visually, and then to specifically tell the pathologist that this is for a prophylactic BSO, so that they will do multiple sections instead of representative sectioning.
Do you know like what the percentage is of patients who undergo an RR BSO that they actually find like an early fallopian tube cancer?
5%?
Mm-hmm. That's exactly right. It's like 4 to 6% that there will actually already be. I actually just saw, this is just human interest. I saw on like one of the Sunday morning news shows, I think it was a week or so ago. You remember Chris Everett, the tennis player? Maybe you guys are too young, but she was a big deal. Well, her sister died of stage 4 ovarian cancer, and she got tested and she was BRCA positive. So they went and they did a risk reducing BSO, and she actually had an early fallopian tube cancer. It was just on. I was like, oh, that's fascinating. So yep, about 5%. All right, great. Any other questions? Thank you, Hannah. All right, so let's go with Erica. Hey, Erica, how you doing?
I'm doing well.
Good. Let me find you here. All right, and are you a generalist?
I am gyne only.
Okay, all right. So let's see, we just did office. So what do you want to do? Would you rather do like a OB?
Sure, let's do it.
Okay. So are you like a pelvic surgery?
Yes, I did a pelvic surgery fellowship with a gynec component and a benign gyn component.
Okay, all righty. So let me just take a look through here. All right, let's do patient number 19. So
Okay.
you had 33-year-old G3P2 at 40 weeks and 3 days who must have come in spontaneous labor. Everything was going great until that head kind of came out and went back in. So you went, oh, darn, I think I have a shoulder dystocia. So I want you to tell me what you did from that moment forward.
So once the head had delivered and we were suspicious of dystocia right away, I had the woman with the help of the nurses go into mcRoberts maneuver, announcing first that we have a dystocia, assessed the direction and the position of the shoulders, and asked for suprapubic pressure, making sure that it is in the correct direction. One of the nurses was in charge of starting the clock once we called the dystocia, and we called in more help. And then in this particular case, with those maneuvers, I was able to then deliver the posterior arm and delivered the baby without a significant event.
Okay, so about 95% of shoulder dystocias will be relieved or I guess remedied with these 3 maneuvers.
Mm-hmm.
Tell me, is there ever a time that you would consider doing an episiotomy to assist with a shoulder dystocia?
I could see a situation where it would be helpful with if I was having trouble accessing that posterior arm because of more peripheral tissue. The times I feel like episiotomy is more useful is actually before the head has delivered. So it's not something that I would routinely do for a shoulder dystocia, but I could see a time where it might help.
What would you have done if you did these maneuvers and that baby was still stuck? What are you going to do next?
Yeah. So I would generally then try some form of a corkscrew maneuver, reaching in and pushing the anterior shoulder down and trying to deliver the baby that way.
All right, it's still stuck. What are you going to do now? You know I'm going to take you to the bitter end, Erica.
Yes,
so,
yes.
You know.
So certainly something that I have never, so there's, I believe, one other maneuver before this, but something I've never had to do, but you certainly have the option to do is push the baby back up and rush to C-section. That is absolutely a last option that I've never done.
Okay, so let's say though you've attempted the 2 different rotational maneuvers and the baby was still stuck. Is there anything else you could do prior to attempting a Zambinelli?
Then I could try an episiotomy and try again delivering the posterior arm maybe after some rotation. Obviously, during this whole time she is in mcRoberts, I would make sure that I have optimal positioning at the edge of the bed and able to apply a lot of pressure. I've never had to go past those maneuvers.
Okay, so when you first recognize the shoulder dystocia and you tell the mom that there's a shoulder dystocia, do you tell her to stop pushing?
Yes.
Do you drain her bladder?
That is something if I'm able to drain her bladder and I had gotten past these first 3 things, I would.
Let's talk about something else. Let's talk about brachial plexus palsy. So there's herbs and there's clumpies. Do you know which is which?
So the herbs palsy is the waiter tip. So C, they're both herbs and clumpies are different palsies of the cervical spinal roots. I believe herbs palsy is C7, C8. And then I would have to double check that.
Okay, and what does a clumpies present like? Because you're right, the herbs is the waiter's tip where the hand kind of goes out. Clumpies, the arm just kind of hangs there. Okay, so anyway, what percentage of brachial plexus palsies are permanent? Do you know?
I do not know the exact number. Most of them will have some, but I would ballpark in the 5% range.
Yeah, it's 10%. So that's good. Now this patient had a shoulder dystocia. The baby was big. How are you going to counsel her about her options for delivery in a subsequent pregnancy?
So having a shoulder dystocia is not an indication for C-section in future pregnancy. However, it is something that might be on the patient's mind, and you certainly always have shared decision making. You can plan on delivering at 39 weeks so that there will be less time for that growth, for increased fetal growth. This patient did not have gestational diabetes, but could consider earlier testing in the next pregnancy and making sure that that isn't something that, you know, if could have some level of insulin resistance might have existed that just didn't meet that criteria. So mostly,
I was going to say, because what are some of the things that would increase the risk for shoulder dystocia? One of the things you talked about would be diabetes, especially gestational diabetes. So that's one thing that increases the risk. What else can increase the risk of shoulder dystocia?
So certainly just the maternal pelvis and shape. Anything that would increase the size of the baby, and diabetes, particularly because you have more central adiposity. Just having, I suppose, a constitutionally larger baby as well.
Yeah, just even a macrosomic infant. However, about 50% of shoulder dystocias actually occur in babies less than 4,000 grams. So it really is one of those obstetrical emergencies that can happen at any time, and we need to be prepared for it. And a lot of institutions have like a, I don't mean to say a code red type thing, but there's a code that you call when it's a shoulder dystocia, and everybody knows what to do and jumps into place. Let me try to think what else. All right, so let's say you had to the baby was still stuck and you had to go back to the OR. So you're saying you're going to do the Zambinelli maneuver, try to push the baby back up in. Is there anything else you could try once you were in the OR short of a Zambinelli maneuver? And if you can't think of it, that's fine. You can say, I give.
Unfortunately, I cannot think of what to do at that point.
Yeah, so I mean, you haven't been doing this stuff for a while, so I'm glad I picked this one, because this is definitely one of the emergencies that I could see them talking about, like shoulder dystocia and postpartum hemorrhage. I mean, everybody needs to know what they're going to do for that. All right, so with the shoulder dystocia, once you recognize it, I think you did a great job, Erica, of saying, I'm going to let the labor and delivery nurse know I have a shoulder dystocia. She needs to start keeping track of the time. I need additional nursing help in here. We're going to tell the mom to stop pushing, tell her that the baby's shoulders are stuck and that we just want to deliver this a little bit differently. We're going to do it with assistance. That you're going to do mcRoberts maneuver, and then you're going to have the nursing personnel do some suprapubic pressure. A lot of times we're lucky the baby delivers then. If the baby doesn't deliver then you attempt delivery of the posterior arm. If the baby doesn't deliver with that, then you go into the rotational maneuvers. Now, if the baby's still stuck, okay, now we're starting to really sweat it, okay? So now we're like, this is bad. Anesthesia may be in the room. Maybe we call for, are there any other OBs on the floor to, maybe somebody else could step in and they could go through the maneuvers and try to see what will happen with that. Then what the recommendation would be, if the patient hasn't had an epidural, you can get her up on all fours. That's called a Gaskin maneuver, and that sometimes can help with the shoulder. But if most of our patients are going to have an epidural, so then what you're supposed to do next is intentionally fracture a clavicle. So you reach and take the clavicle and you pull up and out. You don't push in because you could puncture the baby's lung. You actually fracture the clavicle. Now what you've done is you've reduced the bisacromial diameter. Then you got to go back and repeat every single maneuver, mcRoberts, suprapubic, the rotational maneuvers, etc., because now the diameter's less. The baby's still stuck, you break the other clavicle and you go through and repeat all of the maneuvers again. If the baby's still stuck, you know, you probably have been heading back to the OR anyway, but here's where you've got two options. You can either do the Zambinelli maneuver where you do the cardinal movements of labor in reverse. Okay, by this time, I'm gonna be so freaked out, like I am not even gonna be able to think about what the normal cardinal movements of labor are, much less the other. But that, and to me, this still makes more sense. You do a hysterotomy, and then you can, with direct pressure, try to push that anterior shoulder down and underneath the pubic bone.
Okay.
So that would be, to me, that makes more sense than a Zambinelli, but those would be the two things that you could do in the OR.
And thank you. The fracturing clavicle, it's all coming back to me now. Sorry about that.
Yep. Oh, no, don't be sorry at all, but it's pretty gruesome. You should hear Dr. Shamroth when he does the lecture. Then he talks about doing decapitation, and that's when everybody's about ready to throw up. Like, what, really? But anyway, but a shoulder dystocia is it's an emergency, but this baby was big and you got great APGARs, and it obviously wasn't a really long shoulder dystocia. So yeah, and as for how you would counsel in a subsequent pregnancy, it kind of depends. If she went into labor at 37 and 2 because she had PROM, and you induced her and you suspected the baby was at least 500 grams or less, you know, she can attempt a vaginal delivery. If you're like, oh my gosh, this baby feels, is even bigger than the previous one, I think I'd be saying, I don't think I would not recommend this, you know what I mean, type thing. And you would talk about just offering her a C-section. So you're absolutely right. It is not an absolute, you have to have a cesarean, but you're going to discuss the options and evaluate the current pregnancy with the previous shoulder dystocia. All right, any questions for me?
No, thank you so much.
Thank you, Erica. All right, so let's go to Emily. Hey, Emily, how are you?
I'm good. How are you?
Yep, I can hear. Good, I can hear you. Are you a generalist?
I'm a generalist.
Okay. All right. So do you want to do GYN or office? We can do either one.
Let's do GYN.
All right. That sounds good to me. Do you have a particular case that you would like to go? Oh, you got some TVHs too. Good for you.
Yeah.
Do you have a particular case that you would like to go over or not really?
Not really.
All right. Let me just kind of jump to the back here and then you were busy.
Yeah. Long
Yes,
year.
sigh. Yes, sigh.
Yeah,
Okay, let me see.
long year.
I'm trying to just find something a little bit of interesting. I'm not saying that your list is boring. Don't take me, don't
Oh,
get me wrong. But
never.
I'm looking for something looking for something a little bit odd. But let's see. All right, let's do patient 70. All right, so you have a 37-year-old G1P0 who had a missAB at 9 weeks and she declined conservative management. How do you make the diagnosis of a missAB?
In this patient, she had a crown rump length on ultrasound that was greater than 7 millimeters with no heartbeat. So we were able to make
Okay.
it, or I was able to make the diagnosis on one ultrasound.
So how do you counsel her with once she had a missAB? How do you counsel her with regards to her options for management?
Yeah, so once I diagnosed a missed abortion, there are 3 options for management. The first would be expectant management, so waiting for the pregnancy tissue to pass on its own. Usually I counsel up to kind of 6 to 8 weeks. Risks with or benefits, avoiding the operating room or any medications. Risks are a risk of this not working and the tissue not passing, and needing one of the other options, and a risk of an infection as that tissue stays in longer. The second option is medications, so medications that the patient would take in order to kind of speed up the process. I counsel that this has a bit of a higher success rate than the first option, and kind of shortens the time interval from when that it's going to occur over, but still a risk that not all of the tissue passes. And then the third option is a suction DNC procedure, which can either be done for the correct patient in the office or in the operating room. Benefit is, a 99% success rate with the procedure. The downside is, it's a surgical procedure, so it comes with risks of surgery and potentially needing the operating room, depending on kind of patient preference and gestational age.
Okay, so tell me what prophylactic antibiotic do you give?
I do oral doxycycline.
Okay, tell me about after you did this DNC, when did she start? Did she just immediately start bleeding heavy?
This one, yes, while we were still in the operating room.
All right, so what uterine, okay, go ahead.
I was gonna say I took out the suction curette and then kind of heavy bleeding. Then she continued to bleed heavy right after.
All right, so tell me what uterotonics you gave her.
With her, she was under general anesthesia, so I placed rectal misoprostol, and then I gave her Methergen.
Okay, and then so did the uterus just stay boggy, and that's why you had to eventually put in the balloon?
It did, yeah. I did kind of fundal massage and uterine compression. I repeated my suction DNC again, and she just continued to bleed. So then I placed a intrauterine balloon.
And then kept her obviously overnight, correct?
I did. That's correct.
Okay. All right. So she had estimated lost about 1 liter of blood. What was her post-procedure hemoglobin?
She, I believe, started around 12 and then went to 10.
Okay, all right. Now, what would you have done? So we talked about the missAB, but what would you have done if the products of conception came back hydropic villi in fetal parts consistent with a partial mole? What would that mean to you, and how would you counsel your patient?
With a partial mole, I would say it's a type of kind of abnormal pregnancy. With a partial mole, it could have been one of the reasons that she had a little bit of extra bleeding. I would say this was an abnormal pregnancy that was not unfortunately going to make it to a full-term healthy pregnancy. She has a low but non-zero risk of this progressing to a cancer. And so in that situation, I would continue to monitor her beta HCG hormone levels to make sure that they go to zero. So I would do them weekly.
That's what I was just going to ask you. How would you monitor them? And you were already going there, so go ahead and finish telling me.
Yeah, so with a partial mole, I would go weekly until they're zero times 3 weeks, and then do it monthly. I am a little more on the conservative side, so with a partial, I would go for 3 months.
Okay, and so what else is important during this time that you're following her HCGs? What are you going to counsel her about?
Yeah, so it's important that she doesn't get pregnant during this time, because that would confound my ability to use beta HCG as kind of a marker for GTN.
So what's the difference between a complete mole and a partial mole?
With a complete mole, that one is kind of the chromosomes only come from paternal. Partial has genetic material from both maternal and paternal. Complete has a higher risk of malignancy compared to a partial mole.
Do you know what is the risk approximately of a complete mole to develop GTN?
I believe it's around 15 to 20%.
Yeah. It is. To me, I was so surprised it was that high, but yeah, it is. It's 20%. It's like 3 to 4% for a partial. But anyway, so let's go back to clinically, how do complete moles and partial moles, how do they present differently?
Yeah, with a partial mole, typically they present like a spontaneous abortion. So they measure a little bit small, they have some first trimester bleeding. You can see potentially some fetal parts on ultrasound. With a complete mole, they have much higher beta HCG levels. They can have kind of lots of nausea. Their uterus is enlarged for dates. And then on ultrasound, you don't see any normal fetal parts, and you can see kind of hydropic tissue, kind of a snowstorm.
Yep, absolutely. And they're the ones that can get the bilateral thecal lutein cyst, they can get thyrotoxicosis, they can even get atypical preeclampsia. And then the other thing, especially if they're size greater than dates, oh my gosh, they are the ones that can really hemorrhage when you're doing your suction DNC. Yeah, and you're going to do the same thing. You're going to follow her beta HCGs, make sure she doesn't get pregnant. And what do you know if somebody has a molar pregnancy in one pregnancy, Erica, are they at increased, or Emily, are they at increased risk for this occurring in a subsequent pregnancy?
They are at increased risk compared to baseline.
Do you know like how
the
much
risk of
or how
recurrence? I feel like it's 10% risk of recurrence. So I would counsel on needing an early first trimester ultrasound.
Yep. So here's what they say. So the chance of a molar pregnancy just to spontaneously happen to any of our pregnant patients is about 1 to 2 in 1,000. So that's the risk of it occurring. If you've had one molar pregnancy, you have a 10-fold increased risk. Tenfold, but that still makes it only like 1 in 100. So that's what we can be reassuring to our patients, that although you do have an increased risk, you still have about a 99% chance that it will be a normal pregnancy.
Got it. I was like, I knew it's 10 something, tenfold.
Yeah, no, I know. That's what I was like, you definitely. But this is the area, you guys, in this area here where the examiner could take all these POCs and make them a molar pregnancy.
Yeah,
So
there's a
that's where
mole
they could
somewhere in
kind of
there.
go.
I just don't know where it
Oh,
is.
is there? Okay, all right.
Yeah, I
Well, it
think it's
doesn't
under
matter.
the GTN. I'm an
Okay.
academic, so I just have a ton of these.
Yeah. Oh, got ya. All right. So good. I have no further questions for you. Do you have any questions for me?
No, I think that was good. Thank you.
Okay. All right. I'm going to click you off here. Okay, guys, so we are already a little bit past 10 o'clock, so I am going to call it here, and I will be back with you guys. Let me see here. When do I do my next one? Oh, I've got the next two Thursday ones. Thursday the 22nd, I'll be Sunday the 25th, and Thursday the 29th. So I'm sure I'll be talking to you guys again soon. So anyway, hang in there, and this will all be done in a couple of months. All right, good night.